So we'll move on to our next topic. It will be delivered by Professor Anthony De Souza. He's going to talk to us on severity assessment in bronchiectasis, the present and the future. He's a professor of pulmonary medicine in Newcastle University. He's an honorary consultant respiratory physician at Freeman's Hospital. And then Professor De Souza is internationally recognized expert in bronchiectasis and chronic respiratory infections. He has played a leading role in UK and EMBARK bronchiectasis registries and has been a principal investigator in several landmark clinical trials evaluating novel therapies for bronchiectasis. So we'll listen to the recorded speech by Dr. Souza. Unfortunately, he is not available for questions at the end. Yes, please.
Hello, and thank you for allowing me to participate in this fantastic presentation series. So I'm Professor Tony De Souza. I'm a clinical academic based up in Newcastle upon Tyne, and you probably guessed from my surname I have links with Sri Lanka. My father was born there, so I'm sorry I'm not joining you in person for this meeting. So I'm going to be speaking about bronchiectasis and risk stratification. I'd just like to acknowledge my good friend and colleague James Chalmers, who's kindly shared some of the slides for this presentation. So what I'm aiming to cover is to talk about some of the aspects of pathogenesis of bronchiectasis, and that will try and then help us highlight which patients that we should be most concerned about. And I'm going to try and show that through the medium of some case studies of risk stratification. So, for example, in the UK, we now have estimates of around 300,000 patients based on CT scan and primary care records, and it's a significant illness with mortality. The model for pathogenesis has moved from this original slide called Cole's vicious cycle, where we have microbial infection, inflammation, tissue damage, and impaired lung defenses, to a sort of updated version of the vicious vortex now, where these individual processes have an effect across a spectrum. And for example, since this Lancet paper came out in 2018, neutrophilic inflammation clearly an important part of it. We also recognize eosinophilic inflammation can be an important driver of bronchiectasis. So it's a very dynamic diagram, partly through new science, but also understanding of the interaction between these different elements. We also know that bronchiectasis is heterogeneous, and understanding why some of these conditions or etiologies of bronchiectasis are there are important. We're thinking increasingly there might be certain treatments. Obviously, in different geographies, cystic fibrosis disease is a cause of bronchiectasis, and that's a really important cause to identify because it now has very effective, specific, targeted therapies. Thinking about the current guidelines recommend that we do a history and physical examination, and they have a very early emphasis on CT scan. So bronchiectasis is designated by a clinical syndrome with CT scan. And I know from speaking with colleagues in Sri Lanka, access to CT scan is difficult. So some of the risk stratification here, I think it's important to preface with that not everybody necessarily needs the CT to risk stratify them. Really important to get the CT scan when you can to confirm the diagnosis, exclude other conditions, but also to help target physiotherapy. But it's not a major part of risk stratification. I'll touch on that. So some simple tests can be done, of course, sputum culture, and certainly in developing economies where the risk of TB is higher than in the UK, for example, sputum culture for AFB is really important, not only as a complication of bronchiectasis, but as a cause of bronchiectasis. Some of the tests on the right-hand panel may well be difficult to access, but we certainly are requested to undertake these in patients where we have a high clinical suspicion of either cystic fibrosis or primary ciliary dyskinesia in the UK. And what's coming? Well, perhaps in the future, this is a paper from 2019 from James Chalmers' group, but basically showing that some things can give us biomarkers. So patients with higher neutrophil levels in the sputum are more likely to exacerbate. And there are some bedside sticks. These are not widely used in clinical practice yet, but it tells us perhaps some of the things that we can look with patients get simply at the bedside, but then potentially some near-to-patient tests might come in the future. The guidelines tell us specific etiologies that are associated with targeted therapies, such as allergic bronchopulmonary aspergillosis, where the threshold for steroid use would be much lower. Steroids are not recommended or recommended against in treatment of generalized bronchiectasis with no known cause. Obviously, if a patient has an immunodeficiency and you can access immunoglobulin replacement, for example, that would be important. And if they've got non-tuberculous mycobacterium, then again, you can see that. Some of my patients have got really quite significant gastroesophageal reflux disease, and we've asked our surgical colleagues to do fundoplication with some success. So understanding what's driving the disease is really helpful. What we do accept, though, here's data from the Indian and Chinese registries, that the causes are different across different geographies. So the available guidelines, I think, have to be seen within the lens of the local catchment area and driver. So I suspect the bronchiectasis in Sri Lanka is going to be very much more like the bronchiectasis seen in India, with a higher rate of post-infectious and certainly post-TB, much higher than we would see in the UK. And so this is kind of a similar data set here, just showing that there are significant differences. So each guideline, if it's not developed in your country based on your data, just needs that cautious thought about it. In the US, because the US registry was set up partly through centers with specific interest in non-tuberculous mycobacterium, they have a very high rate there. I suspect that's not how bronchiectasis is in the US, but that's where centers have recruited into the registry. So how can we start to separate the patients once we have a CT scan? The radiology gives us some clues that there might be patterns which help you with the etiology. So ABP is more commonly associated with central disease. In my experience in the northeast of England, where it's not hot and humid for sure, I don't find a lot of central disease. So even these classic paradigms don't necessarily apply. Idiopathic is often associated with bilateral lower lobe disease, and it's got good prognosis. Non-tuberculous mycobacterium is often linked with a thing called tree and bud appearance on the CT scan, often bilateral middle lobe disease, and certainly in the Western Hemisphere, much more associated with thin female patients than other settings. The other thing that's important in bronchiectasis is many of the patients that we look after are old and have multiple comorbidities, and that has an important outlook on their prognosis. As you might imagine, the more diseases you have on top of your bronchiectasis, the more the body struggles to cope with this. So Melissa McDonald pulled together data from the European registry and looked at how common these pathologies were. And I think it's just important to draw your attention to some of these, because some of these actually drive disease and or specific management. Obviously, we've got COPD and asthma here, but we've also got really high rates of osteoporosis. So being aware that bronchiectasis is a gateway into other syndromes and problems is important. Not surprisingly, the patients with metastatic malignancy had a really challenging outlook, but just a reminder for people where there's no obvious infectious cause and you think the diagnosis is COPD with associated bronchiectasis, they had a really poor outcome. That's been replicated in a number of papers. And the other conditions that we see in the Western Hemisphere is associated with more challenging outcomes. Certainly for me personally, inflammatory bowel disease is a group that are very hard to deal with. And you can see there's a significance value here for the connective tissue, particularly rheumatoid arthritis. It's pretty common in our cohorts. And Melissa's paper showed that patients with multiple comorbidities, she described her index as the bronchiectasis and comorbidity index, or BACHI index, was really well associated with both severity, but also with poorer health quality and exacerbation risk. So comorbidity is certainly a part of the story and helps us risk stratify. We're increasingly recognizing that patients with COPD and asthma go on to get bronchiectasis, and we talk about BCOS, bronchiectasis COPD overlap syndrome. They seem to have a really challenging outcome. So again, just to be thinking of them as a group of higher risk. Here's paper from Peter Humany a few years ago now, but just making the point that people who have simple post-infectious bronchiectasis, and by that I mean not necessarily they don't have a severe case, but they have had pneumonia, for example, as opposed to TB, they tend to have a good outcome. And it's a really interesting paradigm, isn't it? I don't understand why you've got your bronchiectasis, but because I can't find any other cause, your outlook's likely to be better. But Peter pointed this out, and we've replicated it a number of times. If you've got COPD associated bronchiectasis, you see the survival rates are significantly poorer. So these might not be quite the same patients that you see, but I think they're useful to illustrate the role of risk stratification. So in panel 1, we have patient 69-year-old female, breathless walking 100 yards, got 3 comorbidities of COPD, ischemic heart disease, and diabetes. 4 exacerbations in the last year, moderately severe airflow limitation, and CT showing widespread varicose bronchiectasis. The sputum was positive for Haemophilus influenzae. Patient 2, 67-year-old female, nearly the same age as the previous case. Whooping cough as a child, but these patients are often, I think, inappropriately labeled as post-pertussis bronchiectasis. I'm going to assume in this case this lady was actually really well for 50 years until she hit her 60s. So I don't think the pertussis 50 years ago is the major driver of this person's bronchiectasis. 6 exacerbations in the last year. It's a really high frequency. If you see that, challenge the clinical history and understand what they're defining as an exacerbation. There were no hospital admissions. Lung function 96% predicted, so well within the normal range. Cylindrical bronchiectasis affecting unilateral right lower and right middle lobe, and the sputum not too exciting. And then we've got a 73-year-old man, history of rheumatoid, 3 exacerbations, pretty good lung function, but despite that good lung function, when he had his last exacerbation, he felt so unwell that he ended up being admitted to hospital. And his CT scan shows quite widespread and severe radiological damage with the cystic form, and he's growing a gram-negative stenotrophomonas multifilia. So we might see those patients in the clinic, or even if you see them without the CT scan in a resource limited setting, you might have to choose which patient you're most worried about. So I'm going to talk through how we do that. So what things could affect the disease? Radiology, microbiology, the etiology, the comorbidity, or the inflammatory pathways. So radiology has been linked with symptoms, exacerbation response to treatment, not so much, but in the far column, you see it's been linked with increased risks of death. So firstly, we recognize there's radiological heterogeneity. You can see quite cystic and varicose elements here. Here's some middle lobe disease. And this person here has got probably Munir-Kuhn syndrome with tracheobronchomegaly. So there are some patterns. There are some scoring systems for looking at bronchiectasis CT scan. And actually the one that's very simply and widely applied is the BALA score, but you can look at the number of lobes affected. And the more lobes affected, the worse. The wider the airway is in multiple lobes, the worse too. So Michael Lobinger, I think, is talking in the same program, looked at mortality figures in a cohort of 91 patients seen at the Royal Brompton Hospital, and he was able to show that the radiological parameters that were associated with mortality were airway plugging, which is fascinating, isn't it? This paper's now nearly 20 years old, and it's now a hot new thing in respiratory medicine that mucus plugs are bad. If you had small airways dysfunction with mosaicism, emphysema, but also the key part, extent. So radiology gives us some clues. What about microbiology? It's absolutely associated with increased risk of high symptom burdens, exacerbation, and has also been linked with death. Most of the data factors around Pseudomonas, and James and Simon Finch undertook this systematic review of the data. And the forest plot down here says, if you look at all the papers published, that if you take the impact of Pseudomonas, it's very clearly associated with more harms. So if you have no pathogens in this outcome, you do much better than if you have any pathogens, but Pseudomonas has one of the worst outcomes. And I understand that it's really commonly encountered in developing economies. So I think it's really important, and perhaps some of this is because patients are having other broad spectrum antibiotics for not long enough. So one of the challenges, can we reduce the risk of Pseudomonas acquisition or overgrowth? I'm not sure people acquire it. I think they've always had it, but we've selected it out by lots of shorter courses. So although the evidence for longer course of antibiotics orally is relatively limited, it does seem to have a useful role in clinical management. And what about etiology? I've already touched on bronchiectasis COPD overlap, and I've sort of hinted that rheumatoid is not so positive a etiology or comorbidity. So you've seen this slide before, but just to remind us of our patients here. So just quick look at these again, and I think most people are drawn, I hope, to this because we're trying to make you look here like an illusionist. Um, um, that person might be the sickest, but actually they've got very good lung function. They've not got widespread disease, and actually they're not too bad. So how can we separate these out with knowing some of the previous risk factors? I'm going to talk about the bronchiectasis severity index and a little bit about the FACED score. So I was really pleased to be involved in this work. It's one of the most widely quoted papers in bronchiectasis now, with a study population of about 1,300. I think just importantly, we have to acknowledge it was done in Europe, and I'll touch on that later. But basically, through clever work, the Dundee team were able to pull out a risk factor which was based on age. So this is not rocket science, is it? But if you're aged 80 or older, you're pretty likely to die. That's not a surprise. But important things that we now recognise in other areas of respiratory medicine. If you're cachectic and lost a lot of weight with your disease, that's a marker that you are struggling. So low body mass index. Lung function test, so if you've got normal lung function, that's the anchor point, and a really big uptick in poorer outcomes if your FE1 is less than 30%. Quite often that we have to accept different healthcare systems have different access points, but if you've been admitted to hospital in the last 2 years, your risk of another hospital admission is much higher than somebody that's never been admitted. So you got lots of points for hospital admission. An exacerbation frequency 3 or more per year gets you quite a lot. Breathlessness, if you're functionally very limited, MRC dyspnea scales breathless and effectively at rest and unable to get washed or dressed himself, really significant. And here's our old friend, our foe, Pseudomonas, giving you lots of point. So importantly, the radiology, although it gives us clues in Professor Lobinger's prior study, it's actually one of the weakest scoring things. So if you've got somebody you just can't get a CT scan, you're happy clinically they've got bronchiectasis, is the CT as important as managing them and being aggressive with the treatment? Probably not. So basically, the score has a range from 0 to 25. Some people criticize this because good parameters only have 5 digits, like curb 65, and that's meant to be because humans think if they count things on their fingers. But these are fairly simple. In my clinic, I often ask the breathlessness score, have they got Pseudomonas to be in hospital, and what's their age and lung function. So this is when I worry less about, simply because you can get a quick look at a scan as and when you need. But severe disease is defined as patients with a score of 9 or more. Previous hospitalization, breathless, MRC dyspnea score 4, and Pseudomonas, that would get you 9 points. And the reason that this has been widely used is that it has really strong associations with core outcomes. So mild and moderate don't have many hospital admissions. If you've had a previous hospital admission, it's a massively strong predictor of a future event. And if you've got a higher score, you're much more likely to exacerbate. With any score, it has its imperfections or limitations. So some people with 3 exacerbations or more, to get them here, don't have that in the next year, which is not a surprise. But the area under the curve here was pretty high and pretty good for predicting both mortality and hospital admissions. So this is operationalized, a nice little website that you can click in and put the details of the patients and score that. Um, so the FACID score is potentially easier to operationalize because it's got less parameters. FEV1 of 2 points, age of gives you 2 points, colonization with Pseudomonas. So you see the previous one um, that you could get some points for other organisms. You don't get that in FACID. And then extension on CT scan and dyspnea. And it worked relatively well in the cohort it was derived in. However, there have been some papers showing that, for example, patients that are younger, fit enough to have a lung transplant for bronchiectasis, but severe enough, wouldn't qualify because they lose quite a lot of points simply because they're younger. So there's a little bit of a natural tension here that this score is slightly easier to do, but it underreports some younger severe patients. So which one to use? There are a number of conflicting papers that show this, and I just wanted to draw your attention to this one here as well, which is more recent, which makes the point that all of severity scoring systems need to be factored in what population you're looking at. I'm grateful to Rajat Dar and also Hyun Choi for sharing the data and slide for this. But basically, this is looking at the Embark registry in India and showing that in the area under curve for predicting severe exacerbations. Now, severe exacerbations are defined as being hospitalized. Obviously, the threshold between Europe and India might be different in itself, but it didn't perform quite as well. I think if you look carefully, though, you can see that the BSI seems to be performing better than both of them, but than the FACID score, but certainly differently compared to what we got in the original European study. Whether that's because the patients are different or the healthcare system's not entirely clear. And that might well be explained by, again, the important part is that median age are really quite different there. And again, remember thinking about the difference in microbiology, enterobacteria was really strong predictor in the India one. So again, sort of taking that local data and applying it. So going back to our three patients that we were discussing for risk screening, I've sort of highlighted ones that sort of map over onto the various calculators. And then just bear in mind, we were trying to draw your eye here, but actually what we should really be thinking was the hospital admissions, some of the comorbidities, and some to a degree the radiological appearances. So this person here has got severe bronchitis because they score above 9, and their comorbidity index gives them a high risk. This person actually has a low BSI, so these exacerbations give them 7 points, but good lung function, never hospitalized, and negative sputum cultures. And this sort of person I do encounter in my clinic, they often are getting too short courses of antibiotics, not doing the simple basics well. And this person here has a BSI of 15 and is also high risk. So you see how these parameters all pull in, but the online calculator is really helpful because it sort of takes out the noise of being distracted with this. So this then sort of plays into some of the patients with mild severity, I think just need to be advised to do physiotherapy and having a more prolonged course of antibiotics, and ideally once or twice a year having a sputum culture. So if they have an exacerbation, it's managed. These are slightly older slide that James developed, but the idea is basically as you get more symptoms, and it may well be that we either talk about severity or more recently thinking about the concept of activity, then patients get more aggressive therapy. So here's data that I published a few years ago, but again, thinking about risk stratifying your service. So this was a paper I published showing that patients with idiopathic or all other causes of bronchiectasis did much better than those with rheumatoid overlap syndrome and COPD as a known comparator. The reason I wanted to draw your attention to the paper is not to show the nice graph, but actually if you look at the rates of rheumatoid across the different services, it was markedly varied. And I was pretty concerned to find the patients with rheumatoid at Newcastle did worse, but actually they had higher BSIs. So, and then I asked my colleagues that in Galway, all the patients with rheumatoid rheumatoid arthritis who were shown to have bronchiectasis were seen by respiratory colleagues as well, just as a default, whereas I was only getting the patients who were really quite sick. So referral bias probably explains the variation across here, but overall this group still did pretty badly. So that's very helpful for me to understand and reach out to our rheumatology team and saying, I think I'm not seeing some of the patients who are in that less severe group that still might need help. So the referral rate's gone up. Obviously, one of the strongest predictors are those patients that have previous exacerbations, but we know that some people, if you follow the red bar here, not everybody stays a high one here. So that's 3 exacerbations. You'll see that some of these people drop off. So there is a regression to the mean. But if you've had 3 exacerbations or more in a previous year, that is the simplest parameter. That'd be the person I'd be worried about. So why do we need to think about this? If you're resource limited and can't scan everybody, then I think we need to think about certain patients. Some patients with COPD who do get a CT scan have a tiny bit of bronchiectasis, and in the Western Hemisphere, they might get referred just to see if there's anything else to do. And I think we now need to say those patients are going to perform reasonably well. And, I'd like to focus more on the young patients with their current exacerbations or the patients with a higher BSI that are unstable. And I think, after somebody's got 4 exacerbations or more, you could argue if that should be 3 or higher, then I think you should be thinking of saying, actually, that is the person I really do want to see because they're going to do badly in the next year. I think it's always worth challenging what an exacerbation means. Clinicians often have a vocabulary in their head, and when they say one word, do you understand what pneumonia is? A great question I ask my trainees, and quite often they go yes, and I say, well, does the patient you've just seen have pneumonia? Yes. Well, what does the patient understand? The patient has no understanding of that. So I've seen patients report up to 12 exacerbations a year, and that's simply because they put a sputum test in and it grew a bacteria, so therefore they were exacerbating. And then you ask the patient, did you have any symptoms? No, but they told me to put a specimen to see if all the bugs had gone. We expect some patients to have a chronic bacterial load in bronchiectasis, and so an exacerbation is defined as a clinical change in their baseline stability. So in summary, bronchiectasis is a rapidly developing field. Thank you to colleagues around the world for contributing to research registries and genetic biobanks and biomarker studies are all coming, and also intervention trials of new medications. Disease phenotyping is its infancy, but stratification for treatment is really helpful. Antibiotic stewardship and using more expensive therapies, really important to think in a resource limited setting, which patients are at highest risk of worsening and which patients can we get scanned, get onto aggressive therapy first. And new therapies, as you'll be aware, are coming. A number of molecular targets are being identified in bronchiectasis, and that pivot from bronchiectasis being solely an infectious process to being a pro-inflammatory setting means that we really need to think about patients. And I think risk stratification is a really key part of that. In the future, I wouldn't be surprised talks like this will also include talking about disease activity. So potentially a patient who's got milder disease but a very active process might respond really well to therapy, but you might say at the moment we're less concerned about them, but they potentially have the most lung function to lose. So I'd like to acknowledge a lot of people that have been involved. This is just a small number of them, my colleagues in Embark and Bronch UK, particularly Eva, Stefano Aliberti and James Chalmers. And I'd like to thank you for your time and attention. I'm sorry I won't be able to join you for the question and answer section later, as I'm actually on leave. So thank you again and wish you the best for the rest of the webinar.